Welcome to A&P Live Studio. I am your host. I teach anatomy and physiology as a registered nurse, guiding advanced-level healthcare professionals. Today, we are evaluating Elias. He is a 42-year-old Caucasian male. In the context of renal pathology, his demographics alone place him in the peak statistical risk group for developing calcium oxalate nephrolithiasis, commonly known as kidney stones. When we observe Elias in the emergency department, his physical presentation tells a very specific story. He is unable to sit still. He is actively pacing the room, constantly shifting his weight, and tightly grasping his right side. His symptom profile is intense, a sudden onset of 10 out of 10 colicky pain, radiating directly from his right flank down to his right groin. His vital signs show that his body temperature is completely normal. We collect a urine sample for analysis. The results return positive for microscopic hematuria, invisible to the naked eye, but indicating red blood cells are actively leaking into the urinary tract. Patients with systemic infections, like acute pyelonephritis, typically present with high fevers and prefer to lie perfectly still in the fetal position. Elias is febrile and pacing in severe pain. Combined with the microscopic blood in his urine, this exact symptom cluster shifts our clinical suspicion away from a bacterial infection and directly toward a mechanical urinary obstruction. To understand why a mechanical obstruction causes this specific presentation, we have to examine the underlying structural anatomy of the posterior abdominal wall. The kidneys reside in a retroperitoneal location behind the abdominal cavity, spanning exactly from the T12 to the L3 vertebral levels. Exiting the renal pelvis are the ureters, narrow muscular tubes tracing a downward path to empty into the bladder. Under normal conditions, urinary flow is not simply gravity-dependent. The filtrate is actively propelled downward by the rhythmic, smooth muscle peristalsis of the ureter walls. Both the outer boundary of the kidney, called the renal capsule, and the ureters themselves are richly supplied by visceral afferent pain fibers. These specific afferent fibers travel back to the central nervous system and synapse precisely at the T10 through L2 levels of the spinal cord. When a patient points to their lower back and complains of flank pain, they are experiencing the central nervous system translating localized mechanical stress within this highly specific T10 to L2 innervation zone. Modern pathophysiology identifies kidney stone formation as a proactive biochemical engine rather than the passive accumulation of crystals. This diagram illustrates the cellular environment of a renal tubular epithelial cell. Sharp calcium oxalate crystals act as an immediate stressor, triggering the activation of the NLRP3 inflammasome, which then activates caspase-1. Caspase-1 releases the potent pro-inflammatory cytokine IL-1 beta. This drives massive generation of reactive oxygen species, causing direct oxidative injury and a positive feedback loop that enhances further crystal adhesion to the epithelial lining. That microscopic cascade builds the macroscopic consequence, a fully formed calcium oxalate stone that eventually detaches, enters the ureter, and completely blocks the lumen. As the kidney continues to produce urine behind the blockage, massive upstream pressure builds up. This hydrostatic pressure triggers intense inflammatory edema, violently stretching the highly innervated renal capsule. Simultaneously, the injured tissues release localized inflammatory mediators, specifically prostaglandin E2 and I2. These prostaglandins chemically sensitize the local nociceptors and force the ureteral smooth muscle into severe, exhausting spasms as it tries to push the stone forward. Patients frequently rate this as the worst pain imaginable. We can see exactly why. They are experiencing a dual force attack. A microscopic IL-1 beta-driven inflammatory fire is compounding a macroscopic prostaglandin-driven mechanical crushing event. We can trace Elias's specific clinical symptoms directly to these mechanisms. His pain is colicky, coming in intense waves, because the smooth muscle of the ureter is actively fighting the blockage, creating waves of peristaltic spasms. When we tap his back during the physical exam, costovertebral angle tenderness occurs because the inflammatory edema and upstream urine have stretched the type A delta and type C nociceptors embedded in the renal capsule, and the pain radiates down to his groin due to referred pain architecture. Visceral afferent nerve fibers from the ureter converge in the exact same dorsal horn segments as somatic afferent fibers originating from the groin skin. The brain misattributes the deep visceral distress as a surface-level groin injury. While dietary factors dictate the availability of oxalate, underlying genetics heavily dictate an individual's innate stone risk, controlling exactly how their kidneys metabolize that oxalate. We see similar pain patterns in distinct genetic conditions like autosomal dominant polycystic kidney disease, where the rapid expansion of cysts creates severe flank pain through sheer mechanical pressure. Whether the physical trigger is a jagged calcium stone, a rapidly expanding fluid cyst, or severe infectious swelling, the rule remains. If it stretches the capsule or spasms the ureter, the T10 to L2 neural pathway will broadcast the exact same flank pain alarm to the brain. Because flank pain is a shared alarm bell, the diagnostic workup must rapidly confirm the obstruction while ruling out dangerous mimics. A non-contrast CT of the abdomen and pelvis is the absolute gold standard for diagnosis. It boasts a 97% sensitivity, accurately identifying the exact size, location, and density of the stone without the need for IV contrast. At the bedside, point-of-care ultrasound is used as a rapid, first-line diagnostic tool. It cannot see every stone, but it is excellent at detecting hydronephrosis, the structural dilation of the renal pelvis caused by the upstream fluid backup. We also rely heavily on the urinalysis. Microscopic hematuria occurs in 85% of stone cases due to the sharp crystal causing urothelial microtrauma. Crucially, the absence of white blood cells and nitrites confirms we are dealing with a sterile obstruction, not an active bacterial infection. That distinction brings us to the most dangerous complication in this patient population, an obstruction combined with an active bacterial infection. If a pathogen like uropathogenic E. coli ascends the urinary tract and becomes trapped behind a blocking stone, obstructive pyelonephritis develops. The stagnant urine becomes a bacterial breeding ground, and the immense upstream pressure physically pushes the multiplying bacteria across the inflamed renal tissue directly into the bloodstream. A sterile kidney stone is painful, but an infected, obstructed kidney is a rapidly fatal emergency, requiring immediate surgical drainage to prevent septic shock. Once we confirm Elias has an uncomplicated sterile renal colic, we map our pharmacological interventions directly to the molecular mechanisms we just identified. The modern clinical protocol utilizes non-steroidal anti-inflammatory drugs, or NSAIDs, as the first-line analgesic over powerful opioids. Opioids only mask the pain in the brain. NSAIDs work peripherally. They directly inhibit COX enzymes at the site of the injury, terminating the synthesis of the exact prostaglandins that are driving the severe ureteral spasms and nociceptor sensitization. The second arm of pharmacological treatment is medical expulsive therapy, utilizing a class of drugs known as alpha blockers. Alpha blockers antagonize the alpha-1 adrenergic receptors located densely in the distal third of the ureter. By blocking these receptors, the drug forces the smooth muscle to relax, widening the ureteral lumen and allowing the stone to pass without triggering aggressive spasms. Targeted medical management resolves localized inflammatory and spastic triggers at the source of the mechanical injury. To master this pathology, apply the Mrs. Includer framework to recognize how a localized flank issue disrupts multiple systemic balances across the body. The urinary and muscular systems represent the primary battleground: structural obstruction, inflammatory tissue edema, and intense smooth muscle spasms. The nervous system handles the severe T10 to L2 nociception, carrying the risk of central nervous system sensitization if the chronic pain windup goes unmanaged. And the integumentary and cardiovascular systems react to the massive pain stress with a sympathetic adrenaline surge, causing the profuse sweating, rapid heart rate, and stress-induced hypertension we observe at the bedside. To summarize, normal urine flow is halted by an active inflammatory crystallization process driven by the NLRP3 and IL-1 beta pathway. This physical blockade triggers prostaglandin-mediated mechanical spasms and intense referred pain along the T10 to L2 nerve roots, a process we can safely reverse through targeted chemical inhibition. Stay pathocurious, and we will see you next episode. This video is for educational purposes only and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions.